So we're changing track slightly to speak about HIV, which has been in some ways one of the real success stories of global health over the last 30 years or so. Although I've put up as the title of this slide is New Frontiers, because I think we are in a new era for HIV care and prevention. And the main theme that is going to be running through this presentation is differentiated care. We can't be doing things as we've done for the last 15 or 20 years. We need to be thinking innovatively and with a much more patient-centred approach and community-centred approach. So you are hopefully all aware that we have UNAIDS targets for ending the global AIDS epidemic. That is, by 2020, having 90% of HIV-infected people being aware of their status, 90% of those receiving highly active antiretroviral therapy, and 90% of those taking treatment having a suppressed viral load. And there's very good evidence now that if your viral load is suppressed, you do not transmit HIV to other people. This is the basis of the treatment as prevention. If we achieve those targets, we would hopefully have less than 500,000 new infections per year amongst adults, and of course we're aiming for zero discrimination. And the key point about this is that antiretroviral therapy is life-saving. These are data from South Africa. I started working in South Africa around about here, just as the program rolled out, and it's been transformative. These are young adults of working age, women, men, children who were becoming infected, and you can see the dramatic increase in life expectancy in South Africa after the introduction of the National Antiretroviral Therapy Programme. So how are we doing towards our 90-90-90 targets? We've got 70% of people infected with HIV globally aware of their status. This is a tremendous achievement, it really is. There's still some way to go, as I'll show. We've got 77% of those who are aware of their status taking treatment, again, tremendous achievement, and 82% of those people on treatment with a suppressed viral load. Okay. This is a real testament to health programs, ministries of health, but also communities and patient advocacy groups as well. And so we're on track to meet our target of having 30 million people accessing HIV treatment by 2030. But I want to introduce this concept of the HIV care cascade. Those first few slides don't tell the whole story of where we are right now. And so this is all of the steps that people living with HIV have to take before they can access effective care and prevention services. So they need to be tested for HIV, they need to be assessed as being eligible, and we're almost at the point where we can take that box away now, because everyone is universally eligible for antiretroviral therapy. You then need to start treatment, and then you need to be retained on treatment with a high amount of adherence. And I think these two boxes, HIV testing and retention on treatment, are where the big challenges for the next 5 to 10 years are going to be. And so this is a global HIV care cascade. So this just translates that previous infographic into some numbers. And you can see we've still got to reach another 7.5 million HIV-infected people with HIV testing. So that's a big gap of people to get tested. We still need to get another 10.2 million people onto antiretroviral therapy. And we need to get another 10.8 million people to have a suppressed viral load. So these are not insignificant numbers. And in some ways, these were the easy ones. These were the low-hanging fruit. And just by way of example, this is what Blantyre, Malawi looks like. We looked at 18,000 consecutive people attending health facilities in Blantyre. And we saw that if you walked through the door of the clinic as an adult, these are adults, if you walked through the door, you only had a 13% chance of being offered an HIV test, which is extremely disappointingly low. These are the people who have come to a clinic because they are sick in a city where 1 in 5 people are HIV infected. So we just are not meeting our capacity of getting people tested. And this explains a lot of the late diagnosis of HIV that continues. Again, this is hopefully disappearing, but we found that only 1 in 5 people completed an assessment, even of those who were diagnosed with HIV. And this is reflected across the world, really. We've got considerable way to go to expand HIV testing access, even though there has been some progress, even over the last year. So this just shows trends in HIV testing, or the percentage of people who know their status between 2015 and 16. So you can see the Middle East and North Africa has actually made considerable progress, but we've got particular challenges in West and Central Africa, where less than half of people who are HIV infected know their status. And we have particular groups where we have considerable challenges in expanding HIV access. Men in particular are an underserved group in terms of HIV testing. And I'll show some data from Blantyre to reinforce that point. And so the full potential as HIV treatment as prevention is not being met. This is a famous HTPN 052 trial that basically shows that if you get people with HIV onto treatment, they do not pass infection to other people. So these are people who were delayed in starting antiretroviral therapy and transmitted infection to their partner. These are people who started treatment immediately upon diagnosis and did not pass infection to their partner. So we need to be getting people diagnosed much quicker and onto treatment as early as possible to stop transmission. But we're not yet doing that. And even though we're going to get more people onto treatment, we are unlikely to meet our target for reducing the number of global new infections. So our trend is not going down quick enough in new infections. That suggests that we're not doing enough at getting people diagnosed and onto treatment early enough. And so we have other new interventions as well. We have HIV treatment as prevention, which I've talked about. We have pre-exposure prophylaxis. So this is taking antiretrovirals whilst you're HIV negative to stop you becoming infected. And we've got good evidence from nearly 20 trials or so across the world in different populations saying that pre-exposure prophylaxis is highly effective. But how do we deliver it to the people who need it? And we also have voluntary male medical circumcision. It's 40% effective in reduction in HIV incidence amongst men. But how do we expand voluntary male medical circumcision services? Okay. And these are what I think are the real challenges for the next 5 to 10 years or so. We're not reaching key populations with treatment and prevention services, and that includes men who have sex with men, injecting drug users, and other marginalised groups. Men particularly are experiencing much slower declines in incidence than women are, and we're seeing an alarming rise in new infections in Central Asia and Eastern Europe as well, particularly related to injecting drug use. And of particular importance, we still have suboptimal funding and resourcing from national programs and from international programs as well. And just to emphasize this point, this is where the resources that we would need to achieve our 90-90-90 targets, and consistently we have been below those targets, and it's unlikely that we're going to reach those funding targets over the next few years. It's always very depressing saying there's lots of problems, so I want to bring up some solutions, hopefully. And this is just to show some of the things we've been doing in Blantyre and Malawi that are potentially applicable at scale. First, I'm going to concentrate on HIV testing, which is really the entry point at getting people into care and prevention. So this is part of Blantyre in Malawi. So you can see highly densely populated urban slum growing at 10% per year. So it's going to be one of these mega cities within a short time. But very poor sanitation and health, and quite poor access to health services as well. So we demarcated communities within Blantyre, 16 of these communities, with about 17,000 or so adults living in these communities. And we trained up neighbourhood members. You know, these are just people living in the community who could read and write. We trained them up to be HIV testing counsellors, and we gave them supplies of HIV self-test kits. And the big advantage with this is that instead of having to go to the clinic to ask for a test, where you've only got a 13% chance of actually being offered a test, you can go to your neighbour's house and say, I want a test, and they will hand you a mouth swab. You can take it home, rub your own mouth, read your own result at home. And that's much more efficient than having to go into a health centre. So we rolled that out across the city of Blantyre. This shows the first year of availability, data from the first year of availability. And the key headline points are that over the first 12 months of self-testing availability, 3/4 of the entire adult population of Blantyre did a self-test, which is pretty impressive reach, and 35% of those people had tested for HIV for the first time. And even more valedictory for us in some ways was that we were reaching these groups who were at highest risk of HIV, so young men and young women who don't otherwise test. We repeated this for a second year and showed pretty much identical figures as these, so it's sustained over a period of time. So self-testing is new, is coming on the horizon. The UNAIDS funded STAR program that's running in Malawi, Zimbabwe, Zambia, lots of other countries now, is aiming to reach 30 million people with HIV self-testing over the next few years. And hopefully it can reach those groups that don't access testing in other ways. How do we get people from a positive HIV test onto treatment? This is the linkage question, and we have considerable dropouts along the way. If you remember my figure from Blantyre, we only get about 1 in 5 people directly onto treatment. And again, very depressing figures here of various modes of HIV testing, showing what percentage of people will then go on to successfully start treatment after a positive HIV test. And this is really unacceptable. I mean, we're giving people a diagnosis, or they're getting their own diagnosis, but not getting the treatment that they need. So we need better ways at linking people between testing and treatment. So again, this is an example from Blantyre, where we had our 17,000 or so people living in 14 communities, and we randomized them to say that if you had a positive self-test, please go to the clinic and ask for treatment and they will assess you there. Or you can ask that a nurse comes to your house on a motorbike and does all of the assessments and starts you with treatment at home. So this is optional home initiation of antiretroviral therapy. We provide 2 weeks of drugs at home and then you link into the clinic system thereafter. And what we showed is at the population level, we had 3 times as many people starting antiretroviral therapy, where we gave the offer of starting treatment at home. And I think this speaks to the differentiated care aspect, is we can't be expecting people who are incredibly poor with lots of competing demands to take time off of work, off of school, etc., to go to the clinic on repeated occasions and bankrupt themselves in the process. We have to be bringing services to people who need them. And very finally, the final step in the cascade is the retention and treatment and achievement of viral suppression. And this is challenging here. We have got very effective drugs that will achieve viral suppression in nearly everyone who takes them. But how do we get people to take those pills consistently? How do we get them to keep coming back and forth to the clinic every month or every 2 months to collect their supply of antiretroviral therapy for the rest of their lives? So we have got some areas of innovation here, but we do need a bit more work. The first one is integration. And integration basically means getting away from this vertical model that we've done for the last 15 to 20 years of the HIV care program delivers ART only within HIV care clinics. So we need to be providing ART within TB clinics, within outpatients, with antenatal wards, specialist clinics, diabetes clinics, under 5 clinics. And there's a huge resistance to this right now because the HIV program has been so successful at getting people onto treatment. But to reach the people who need treatment, we're going to have to expand outside our comfort zone. And we haven't got yet a huge amount of evidence to say how to do it. How are we going to do it? It's going to be very difficult. We're going to have to train a lot more people in providing ART, recognizing side effects. There's concerns about infection control with tuberculosis. We're going to need much better technologies, patient ownership of their health records, and access to drugs. We're going to have to be innovative in how to do that. Does it work? Well, we have got essentially no evidence about this yet at all. This is a real neglected area in terms of research. Decentralisation, we're some way towards decentralisation, and this means taking HIV care out of the hospitals and into the clinics and into the community. We've done a bit of that in Malawi and in Blantyre, but we haven't yet done enough. We need better models for community-delivered HIV care. And it works. The evidence from the Cochrane Review says that you have much better patient outcomes if you take care outside of hospitals. You get people to stay on treatment and they die less as well. And finally, task shifting. And so WHO defines task shifting as delegation from doctors and nurses to stop me sitting there having to write every prescription. We can train up community health workers, clinic officers to provide the HIV care as well. You still need specialists because you do occasionally get complicated HIV care patients, but the majority of HIV care needs to be provided by a much lower cadre in the health centre. And why do we need it? Well, I mean, this graph is incredibly disappointing or depressing to me in some ways. So it shows the log 10 number of physicians per 1,000 population against the HIV prevalence up on the y-axis. And you can see this is where you don't want to be, with a very high HIV prevalence and no physicians. And that's basically southern and eastern Africa. So you can see Malawi right up here. So we just do not have the capacity for nurses and doctors to be providing antiretroviral care. We have to expand. Does it work? Does task shifting work? Well, there's pretty good evidence that it does, but we haven't yet got a reliable system within health systems to roll this out at scale. So just to summarize HIV, we really need a renewed focus and a renewed thinking about how we're going to meet our targets for HIV, and that is going to focus around differentiated care. We need local solutions. These need to be driven by the community. What works in Blantyre is not going to work in rural Karonga province. And health system strengthening is absolutely going to be the key here for HIV.